what PPPs are and how they affect your life? Hi, my name is Sue Gott. I've had the privilege of living and working across Africa for most of my adult life, and I've seen the devastating impact of this type of development. I'm very proud to be working with Dawn to bring these stories to you.
Welcome, everybody. As you all know, Dawn is a leading organization in development studies, development analysis, specifically from a feminist perspective. And during the last few years, we have been involved in challenging the narrative and the practice that leads to a marketization of development strategies that locates the private sector as the key actor for development. And as part of this broader project of what we call the corporate capture of development, we have carried out a set of case studies that focuses on experiences of public-private partnerships, because we were eager to build stronger evidence about what it means to promote these PPPs at the country level. And one of those cases was the case of Kenya, and we are very happy to have today the voice of Wangari Kinoti and Crystal Simeoni, who are the authors of that case. So let me introduce Crystal Simeoni. She serves as the NAWI Collective Director. She has over 10 years experience working on macro-level inequalities. She currently works on women's rights and macroeconomic policy at regional and global policy spaces, which means advocating to ensure there is a Pan-African feminist analysis influencing policy at continental and global levels. And Wangari Kinoti is a Pan-Africanist feminist activist currently engaged in global policy advocacy on women's economic justice, structural gender-based violence. Over the last 16 years, she has campaigned and implemented programs through civil society and social justice organizations covering women's political participation, women's land and natural resource rights, corporate accountability, women's paid and unpaid labor, and violence against women. So thanks again, Crystal and Wangari. And before delving into our conversation about the PPP case in Kenya, we would love to learn more about your own trajectory as Kenyan feminists. So my first question would be, what brought you into feminism?
Thanks, Karina and the Dawn team for having us and curating the space and holding the space for this series of papers, which are so important. I was thinking about this week, and I think really it's my mother. I was reading messages between my cousin and I when I was about 16, and we were talking about boys. And I remember telling my cousin, I can't tell my mom all that stuff. She's always on this feminist tip about power and agency. And I didn't even remember until literally last week. And so I think in her own way, she molded me into being a feminist in ways that I didn't even recognize and realize. And she's still a very strong influence in my life. And I know it's very cliche, but it's my truth. It's my mom.
Thanks so much, Crystal. That's wonderful. Sometimes it's the other way around. We have to fight against our mothers who are reluctant to our own feminism. Wangari, you want us to tell your story?
Sure. Thanks, Karina and the Dawn team. I also echo Crystal's thanks for this really important project that you brought us into. And before I talk about my own story, since I know Crystal's mom, I want to thank Crystal's mom for bringing Crystal to feminism, because otherwise I probably would never have met her. Some friends remind me that even quite early, sort of in primary school, I used to talk about women's liberation. That's how it was being referred to then. I would write essays on it, etc. I don't really remember a time when this was not in my consciousness. Okay, so there was no particular turning point for me. My first job after university was at a national women's rights organization. I was fortunate to get it because it defined for me what I was really interested in doing. It was focused mostly on supporting women standing for political office in elections. And although I had a sort of theoretical sense of the problem, working in an organization that was dealing with this gave me firsthand knowledge of, sort of how misogyny, patriarchy, the nature of the political structures in Kenya were constantly throwing up these barriers for women. But once I started, I knew that this is what I wanted to do for the foreseeable future, not just on the issue of politics and elections, but on bringing down those structural barriers. This organization was also the organization where I made some of my closest friends to date. Since then, I've worked in different roles, on different themes. So that was in my early 20s, and my feminism has naturally evolved since then. Because quite early, I was uncomfortable with the domination of Northern feminist narratives that didn't necessarily hold true for my experience as an African or as an African feminist. Yet I was born of a mother who centered Africanness in almost everything she did, from how she raised us to how she dressed to her academic work and everything else in between. So, it's this kind of introspection and lots of critical fireside conversations with other African feminists that brought me to this place where I'm now, with sort of more clarity on my position and my purpose.
Thanks so much, Wangari, for sharing your feminist journey as well. So coming now to the case, Kenya seems to be an excellent example of the process that Africa has been undergoing, where the narrative on Africa rising has been accompanied by the idea that such rising is only possible bringing in different ways the private sector as this key development actor. Is this how the narrative is perceived nationally in Kenya?
Yes, it is. It shouldn't actually be surprising, because the Africa Rising narrative is a neoliberal one used to explain both the ongoing and aspirational rapid economic growth, GDP growth of the continent. The IMF itself has convened conferences where the theme has been Africa Rising. Alongside other stereotypical metaphors, the IMF MD at the time described Kenya, Uganda, and Botswana as frontier economies that roaring loud as African lions. She also describes how the largest share of the IMF's capacity development services is devoted to Africa, and how the fund is always ready to lend financial support, policy advice, technical support to the continent. So we're no longer sort of surprised by the lack of a sense of irony that the fund and other financial institutions show. In the mid-90s, there were more expatriate advisors than there were at the end of the colonial period, leaving very little room for African states to define and chart their own policy agenda. Perhaps the only difference now is that there's little to no resistance to liberal policy in government, in universities. At least in the 1990s, there was some resistance, particularly in Emir, but this was quickly drowned out. The crisis in African universities generated by reductions in academic wages created an opportunity for donor-driven aid packages that basically retrained old faculty and produced a new generation of economists under the Western classical model that provided the basis for neoliberal policies. So when you combine that sort of more recent history with the following decades of neoliberal policy and a youthful population that has no first-hand experience of a real public service, public funded and delivered, it's easy to swallow the lie that anything that isn't private-centered, designed, delivered, etc., will not work. So an Africa Rising that is truly public, not blended finance, not private investors and capital, is beyond this public imagination right now. And that's really a tragedy.
Thank you very much, Wangari. It's Sue here, and I'd like to follow up on the point you were making about public-private partnerships, or PPPs, and how they've evolved within Kenya. On one hand, we know that Kenya adopted a very progressive constitution in 2010 that was grounded in principles of democracy, participation, equity, social justice, human rights, protection of the marginalized. And yet, over the years, there's been significant investment in developing both the legislation and mechanisms that allow for PPPs. Numerous partnerships have been developed, and this has raised concerns amongst many people. So clearly the Constitution has not been able to prevent this implementation. So I wonder if you could discuss how this PPP model fits within the Kenyan Constitution and legal frameworks. Are there any contradictions or tensions?
Yes, it's a really broad question. I'll just give a few thoughts. So yeah, Kenya definitely has very sort of robust public-private partnerships infrastructure. We have a Public-Private Partnerships Act, and this was amended in 2021, which establishes a PPP committee. This is the committee that approves PPP projects and so on. At the time we were writing the paper that we're discussing, the entire PPP program was supported by Infrastructure Finance and Public-Private Partnerships Project of the World Bank, which had close to 40 listed bilateral and multilateral development partners. There are also a whole set of PPP regulations, also passed in 2014. And the PPP Act of 2021 allows PPP agreements directly between county governments and private entities and provides more provisions for the implementation of PPPs by county governments. So that's a significant change. The Act was also expanded to allow direct procurement, privately initiated proposals and competitive bidding and restricted bidding, including single sourcing. So I think the biggest question for us here when we were thinking about all this is not even so much in those details, but in the wider constitutional guarantees of Kenya's constitution. And as you say, the tensions with public-private partnerships. So the constitution states that all sovereign power belongs to the people of Kenya and that the people may exercise their sovereign power either directly or through their democratically elected representatives, and then there are the state organs that flow from that. So what we found is that despite all the regulations and checks and balances in place, all that exists on paper, PPPs are a door to the usurping of the sovereignty of the people, exercised through the state for private interest. This, of course, is not unique to Kenya. We know this. Our constitution, though, also guarantees certain rights, reasonable standard of living, at its highest attainable standard of health, including the right to healthcare services, accessible housing, shelter, freedom from hunger, clean and safe water, social security, education, and so on. Yet we know that in whatever form, PPPs restrict access to services that deliver rights to those that can afford them at whatever price point has been set, which is the direct opposite of the constitutional guarantee. The Constitution also enshrines a long list of national values and principles, including participation of the people, human dignity, non-discrimination, protection of the marginalized, good governance, integrity, transparency and accountability, sustainable development. And our project and many others before it have found that PPPs are certainly not bound by these values beyond paper. So really, in an ideal world, PPPs should be declared unconstitutional.
Thanks so much, Wangari. I think these tensions that you were highlighting between the rights that are guaranteed by the Constitution and the impacts of the PPP are made clear when we go to the specific cases. And this is the case of the managed equipment services that you studied in your chapter. So, Crystal, can you summarize the full story of this case study? What is the current status of that process? What has happened more recently since the case study was written? And what is the prevailing narrative and how was the narrative imposed? What was the role of the media and of other relevant actors in imposing this narrative, allowing for these PPPs to be there even when producing this tension with the rights guaranteed by the Constitution?
Thanks, Karina. I'm going to paint a backdrop. So first, it's important to remember that healthcare is devolved as a function to the 47 counties of Kenya. We do health policy making at a national level, but the management and rolling out of healthcare is done at the county level, which is managed by county governments. It's also important to remember that health is one of the 4 pillars of the current government's developmental plan, and so is key in sort of conversations and prioritization of developmental paths. It's also important to pan out a little bit and to have the backdrop of what the World Bank has been thinking and pushing down the throats of many former colonized regions and nations, the idea of maximizing finance for development, and specifically the cascade approach of the World Bank that really pushes governments to open up to private finance and de-risk their investment of private finance in public services. So if you have a problem with your health services, the World Bank is like, well, we have a private solution for you. You need to change your policy framework and legislation framework to make it accessible to private finance. But on top of that, you need to be able to de-risk their investment since you are high risk, and so guarantee essentially a profit that they will be making irrespective of what goes on in your country, whether that's climate, whether that's war, whatever it may be. The country must, guarantee a profit to this private finance for their investment. So back to the managed equipment scheme. It's a project that was introduced in 2015 to lease specialized health equipment for a period of 7 years. So things like radiotherapy equipment, theatre equipment, dialysis, like very high level machinery. And this was to be allocated to 2 hospitals per county. Remember, we have 47 counties. And so it would be, leasing equipment to 98 hospitals across the country. And the contracts for the leasing of this equipment went to 5 international companies, Shenzhen Mindre X-Ray from China, Esteem Industries from India, Belco SRL from Italy, General Electric from America, and Philips, which is Dutch. And so with this whole scenario, there are a couple of issues that came up, but most importantly, cost and transparency. And I'll give an example. Our fiscal budget of 2016-2017 showed that the leasing of the machines was our third highest health budget spend. And that's pretty high for equipment that we're leasing over and above other services within the health sector that really should have been prioritized. Secondly, on transparency, there's been a complete lack of full disclosure. There's nothing about what informed the choice of this equipment, were these really what was needed at these hospitals. Nobody has seen the contracts, and so nobody knows what was in them and exactly what are we paying for and what are we getting, who maintains them and at whose cost. And these are questions that have come up over and over again with no transparency of what it means and what these contracts have. And I'll give you an example. In northern Kenya, between 2008 and 2009, the northeastern region of Kenya, in a survey done, 68% of women were reported to not have access to maternal hospitals because the hospital was just too far. And so again, bringing to light a question of who decided that they needed this high-tech equipment over very basic medical care and facilities. The amount for the leasing was at 95 million shillings annually per county. And this weird turn of events in about 2018, and we were not able to understand, what caused this, but this amount more than doubled to 200 million shillings per year per county, which is equivalent to about 1.7 million USD per county, with absolutely no justification as to why there was such a drastic increase in the cost. And remember all the while that this money that is paying for the leasing of this equipment is coming from the taxpayers. The Chinese company is on record saying that what we spent on the leasing equipment is 3 times more expensive than just outright buying the equipment. So again, even if we needed this equipment, which there's questions around, why did we choose to lease rather than an outright purchase? And what informed this decision? So the saddest thing is that many of the hospitals this equipment was going to didn't have a number of things. They didn't have 3-phase electricity. They had no running water sufficient to run the equipment. And there really weren't enough requisite doctors who had the technical knowledge to operate the equipment. So many of them lie unused up until today at these facilities. So we seem to have very many scandals going on, and with a lack of clarity and transparency, the story has sort of gotten lost in the melee of things and then the melee of COVID. And it's been sort of silent. We've been tackling COVID, but this year in January, there was an announcement in the news that the contracts would be extended for a further 3 years. The initial contracts started in 2015 for a period of 7 years. And there's also a committee that's apparently been set up to investigate what went wrong over the last 7 years and why in a number of hospitals, 7 years on, the equipment is still yet to be used. And so even with all the evidence that a good number of hospitals not being able to use this equipment, we're still going ahead to renew the contracts for a further 3 years. What that decision was based on is still not clear. What the details of those renewed contracts are is still not clear. And so there's still very many questions around what informed it. There's questions of who prioritizes these contracts and what the cost is, especially in a country where public participation is such a huge part of our constitution. But we'll talk about that a little later on.
I'd like to follow up a little bit about what the impact is on systems and people. So as you've so clearly spoken, the MES case study clearly exposes how healthcare priorities have been distorted. And as you had mentioned, Crystal, there's clear example after so many years of some of the equipment not even being used at all. But at the same time, there's a lack of resources to address the most basic health needs of the population. And the focus really seems to also be skewing the system more towards treatment and care rather than on prevention and health promotion. Wangari, I wonder if you could maybe expand on this and reflections on what the impact is on the change in priorities.
As we now know, and indeed as we experienced, Crystal and I writing this paper, there was a lack of full disclosure by the Ministry of Health and other entities on the actual MES contracts. According to a document from the Senate, some facilities were not even fully aware of the exact equipment they were expected to receive and benefit from. This leaves us open to speculate that some of the MES providers are suspected to not have supplied complete sets of equipment to the facilities. Nevertheless, even based on the equipment that we are aware of, one of the most common complaints raised by the county governments before the Senate committee that was looking into this particular PPP was the fact that they were not even involved in discussing the needs and service delivery priorities in health for the county, which would then inform the delivery of the equipment. So as a result, a lot of equipment has remained unused from our research in at least 29 of the 47 counties of Kenya. And this was as a result of a lack of requisite staff to operate the equipment, but as Crystal mentioned earlier, inadequate water and electricity supply as well. Because many of these counties are geographically remote and typically marginalized areas, it is no surprise that they have constraints when it comes to water, when it comes to electricity, or indeed specialists to manage the equipment. A year after the MES program was launched, Kenyan doctors went on the longest nationwide strike that we've ever seen in the country's history. And, it culminated in the jailing of the leaders of the doctors' union. So the strike was basically around fairer remuneration and better working conditions. Because as it stands, on average, there's only one doctor for every 6,355 Kenyans. And even that doesn't really paint the complete picture because of inequalities in distribution. So huge and stark inequalities in distribution of doctors. And that's just doctors, not talking about nurses, lab, radiology, all these sort of technical specialists that would be required to run and manage this equipment. One major issue we found with this scheme, and this is speaking to the wider question around prioritization, was employing a one-size-fits-all approach to a problem that obviously would present itself in unique and diverse ways in different counties. So it's clear that there wasn't sufficient due diligence, consultation between national government and county governments in order to even determine what equipment was needed. So this meant that some counties either received equipment that would not have been top priority for them, or that they received equipment that they already had received from different government schemes. So they ended up with even more equipment than they would ever need. The even bigger problem here is that our health sector models in Kenya, much like the rest of the continent, which are based on sort of philanthropic, capitalist and developmental assistance to the health sector, is by nature predominantly vertical and siloed. So they support sort of single health issues or perceived needs, such as specialized infrastructure, and that's taking up large percentages of. We see a big problem here with the prioritization process. And this was a common and recurring theme even as we were doing this research. Dr. Richard Aya is a Kenyan public health systems academic, and he is constantly lamenting that our best health systems are foreign owned. So if we don't have a robust public and community health infrastructure that's owned and managed by the state which is really the representation of the sovereignty of Kenyan people, it becomes next to impossible to have control over data or information that will inform as well as effectively implement health interventions to adequately keep populations healthy, which is the promise of our constitution.
I know that Kenya has a long history of developing bottom-up, comprehensive community health approaches that really address community-identified health-related priorities, often, for example, around getting clean water, which we know would solve so many of the basic health issues. And there's been so much work done around strengthening community engagement, governance, and accountability mechanisms. So there is this incredible foundation that's been in place for so many years. And yet it looks like these approaches are really being threatened by PPPs and by this whole modality of financing. But focusing on women's specific needs, what impact does the PPP have on women's access to health services? Any thoughts?
Thanks to PPPs put a cost to a service that should be covered by government to ensure all citizens have access to universal health, regardless of their station in life, their location, their sex, and their gender. The end game for private sector will always be profit and a maximization of profit. Held up against a public service, women who are always on the fringes of economies and services are always the first and the most deeply affected by these policies. A woman who takes her babies to a hospital, a woman who's trying to have a safe delivery for a child. All of these mean that women, have front row seats to really the violence of these economic policies that all our countries have gone through.
I guess there is also this privatization through PPPs also reinforce the burden of unpaid healthcare work of women. So I wonder, Wangari, whether this is the case in Kenya. There is not only more limited access to health services, but also an increase in the burden of unpaid healthcare work. And I also wonder if there is a kind of mainstream gender narrative in Kenya and whether this applies to this specific case and what are, from your point of view, the risks of this mainstream gender approach.
For Kenya, we weren't able to find particular data, or rather data that was disaggregated by gender. But generally, we found that, across the global south, women's out-of-pocket expenditure had been found to be systematically higher than that of men, at least in part because of the high financial burden related to delivery care and other reproductive services for themselves. In fact, a study in Zambia found that expenses related to delivering in a maternity facility account for approximately 1/3 of the monthly household income of the poorest households. We can probably sort of project that would be about the same for Kenya. But to your question, yes, we know that women's labor subsidizes for collapsed public services, including, collapsed health services. So women take on the work of caring for the sick and often at great personal health, well-being, and financial cost, including by taking up huge household debt. The other thing is that because of the sort of amount of time and energy spent on unpaid work, women are forced into precarious and low-paying jobs with insecure contracts and certainly no social security protections. But the thing is, because of these low-paying and precarious jobs, healthcare, which is still privatized, is further put out of the reach of these women in this really, really vicious cycle. Just quickly to the question around gender mainstreaming, the approach is very narrow. So looking at income generation, access to finance, microfinance, skills training, entrepreneurship, all those things that I think we're all kind of familiar with. However, we know that this doesn't really do much to change anything structurally. And here we're dealing with the structural problem. So we're using individual strategies to solve a structural problem where we could actually solve the major chunk of this problem, if not all of it, if we guaranteed all women universal access to public services, paid for by taxes, raised in a progressive manner. Okay, so paid for by public finance. Instead, we're trying to raise individual women's incomes so that they can pay for privatized services, which we probably wouldn't be able to afford anyway. So there's a lot of work to be done there from moving from this sort of women's economic empowerment models, again, looking at single issues, single rights, to taking a more structural approach that looks at changing the system, including the economic system, so that it works for women, rather than trying to increase women's ability to survive in an unjust system.
So as we come to the end of this podcast, I would like to ask you for a last short comment on what alternatives could emerge to challenge PPPs, and more generally, what gives you hope in this context. So Wangari, if you want to start with your last comment.
Thanks, Corina. I think, looking specifically from the African context, it's going back to what was the post-independent aspirations of governments and leaders at that time. And a lot of it was around reversing the damage that had been done by colonialism that created these hierarchies in terms of who was more important, who could access what, at what price, and, creating those sort of societal divisions. So it's looking at that, sort of reclaiming those visions, applying them to the current context, reclaiming services as public, which means that they should be publicly funded, that they should be publicly delivered, and that they should be accountable to the public, and that nobody should be locked out of accessing a service because they can't afford it. And that's the whole process of sort of reclaiming rights and dignity for our people. But on the question of what is giving me hope, we began with the question of Africa rising. My hope is in Africans rising. So rather than Africa rising, Africans rising. And we have seen it with the young people's movements, most recently in South Africa, Nigeria, and elsewhere. But over the years, we've seen this, not about PPPs per se, but more generally about structural injustice and sort of reclaiming sovereignty. It's the young and not so young feminists across Africa and in the diaspora, the growing collective of people showing kind of a renewed energy to learn from the past, to reject external narratives, even about ourselves as Africans and more generally as people from the global South. So rejecting those sort of narratives and impositions that don't serve us, So my hope is in all of us who are collectively creating these visions to reclaim power, to reclaim rights and dignity for all of us.
Thanks so much, Wangari. This idea of Africans rising is great, and to do it in a collective way. Crystal, your last comment?
I'll quote Wangari Maathai, who says, what people see as fearlessness is really persistence. And so this idea that we must constantly be banging on the very same tenets of what we're fighting for, because it really is the same. And together and collective action really will give us our liberation. So it gives me hope that I'm able to be in this fight with sisters like yourselves, Karina, Dawn, Wangari, all the people, all the women, all the feminists that I fight shoulder to shoulder with. And that community is growing, and growing not just in number, but in passion, in resilience. And I'm not really a fan of this idea of resilience, but I will say in persistence as well.
Thank you so much to both of you, Crystal and Wangari. It's a privilege for us to have your African voices nurturing this podcast. Thank you so much.
This podcast series was produced by Dawn, Development Alternatives with Women for a New Era. Today's episode was edited by Elise Furtado and engineered by Ernesto Sena. Thank you for joining us. If you would like to learn more about Dawn's work on public-private partnerships, visit our website at www.dawnnet.org. I am Masaya Llavaneras Blanco. See you on the next episode.